This conference will now be recorded.
Okay, so it was another gentleman. I think actually it was-
I'd like to call this regularly scheduled, this is Mayor Ken Tedford, I'd like to call this regularly scheduled a meeting of the Central Nevada Health District to order. If we'd all stand and pledge allegiance to the flag. Thank you. At this time, would you take roll, please?
Chair Ken Tedford,
Here.
Justin Heath,
Present.
Pete Olson,
Here.
Tina Mandini, Don Witten, Bob Erickson,
Here.
Denise Ferguson, Tyson McBride,
Here.
Larry Rackley,
Here.
Jeb Rowley,
Here.
Rich McKay.
Okay, I think that leaves us with a quorum. Thank you. We'll go to item 5, the verification of the posting of the agenda. Has it been done in compliance with NRS?
Amber Edwards, for the record, verifies that the agenda for this meeting was posted on the 5th day of April 2024 between the hours of 2 and 5 p.m. at all of the locations listed on the agenda.
Okay, thank you. We'll go back now to public comment. Is there any public comment today? It must be general in nature, not relative to any item on the agenda. Discussion can be held, but no decision can be made. Public comment? Hi, Bob. It just needs to get green somehow.
That doesn't do it.
There you
Okay,
go.
thank you very much. For the record, Bob Clifford, Fallon resident, Mr. Chairman, and board members, including a new board member, Pete. I don't recall you being on the board. Provided here in the handout, and hopefully you'll get a file so you can click on links, because these are way too long to type in. More news articles, alternative media, by the way, about the mRNA genetic vaccines and their deadly effects. There are more and more people calling for complete cessation of their use, and now there are calls for prosecution of those involved in rolling it out and developing it for crimes against humanity. And some pretty credible, when Elon Musk comes out publicly and says, we need to prosecute Anthony Fauci and incarcerate him, that has a little bit of credibility to it. In the United Kingdom, they're actually formally prosecuting government officials and some officials in the pharmaceuticals for manslaughter on a massive scale. And there's a link. There's a link on that in here. The death toll is enormous. The excess deaths have been running 10%, and then we'll talk about how that's probably going to go way up. But the sudden deaths continue. You see it all the time. Young, healthy athletes dropping dead on the soccer field or in sports and that type of thing. And the turbo cancers now are really getting big, and the analyses that have just come out, the turbo cancers are among the vaccinated almost entirely, not the unvaccinated. So, it's hard to pin down the cause and effect on these, but it sure is becoming a compelling case that the turbo cancers are due to this. And as I'll talk about, there's a reason for that. So the CDC and other agencies, FDA, they're not investigating the high level of excess deaths they won't even release the data. You have to get it from the insurance industry or other sources to find out about this stuff. They're hiding it. And they have no interest in investigating. But it's the experts, the immunologists that are analyzing the vaccine are saying it's designed for depopulation on a massive scale. And they're saying also that there's going to be a tsunami of deaths coming, and that the death rate is going to go way up above the 10% excess deaths. The analysis that's coming out is that the turbo cancers, the vaccine is loaded with, I don't know, like per dose, 200 million DNA fragments, and these DNA fragments are known to be a cause of cancer. And then the jabs impair T cell function, so your body doesn't have a mechanism to fight the cancer. So you cause cancer, you eliminate the ability of the body to fight the cancer, and you get a turbo cancer. And these turbo cancers, people typically, they go so fast they find out they've got cancer when they're stage 4. And they're in really bad shape at that point. So, you know, I think you're going to see what people are calling for, like Nuremberg-type trials for crimes against humanity. Just don't believe anything you hear in the mainstream media, FDA, CDC, NIH, or from Pfizer. There's an evil agenda at play here, and you just can't trust them. Those organizations are loaded with people that are members of the World Economic Forum. Klaus Schwab, those guys. Bad people. Anyway, thank you.
Okay, thank you, Bob. We'll incorporate your remarks into the record. I appreciate your time today. We'll go to item 6, consideration possible action, approval of the minutes of March 14th, 2024. Are there any corrections or additions to those minutes? Let me stop right in the middle of that. I forgot. We have Pete Olson's here for the first time since he's been appointed by the Churchill County Commission, so I want to introduce him to you on the panel here that's today, and those of you that are on the line, letting them know that Pete's here, and he will be a great addition to the Central Nevada Health District. Was instrumental in its formation when he was chairman of the commission for Churchill County, so it's good to have you here today, Pete. And I apologize for not doing that earlier, but I'm so used to having you around, I forgot. Okay, back to any changes to those minutes or corrections of the 14th of March. If not, I'd entertain a motion to approve those.
Mr. Chairman, I would move that we approve the minutes of the meeting held on March 14th, 2024, as presented.
And for the record, Larry Rackley, I'll second that motion.
We have a motion and a second to approve the minutes of March 14th to 24. All in favor?
Aye.
Aye.
Opposed? None opposed. The motion carries and the minutes have been approved. We'll move to 7A, consideration and possible action concerning approval of notice of a subaward between Epidemiology Office of the State Epidemiology and the Central Nevada Health District in the amount of $5,000 to fund activities for the prevention and control of M. tuberculosis pursuant to Nevada Administrative Code 441A and revised statutes 441A, and conduct activities per the scope of work from 3/20/24 through 12/31/24. Darren.
Mr. Chairman, members of the board, for the record, Darren Winkleman. This is funding that supplements another grant that we have doing basically the same work. Again, with our state partners, found a little bit of additional money for us in the amount of $5,000 to help us with our TB disease surveillance, rapid identification, case management if needed, working a little bit in the latent TB case management. And again, just a little bit extra money to help us do the work that we are doing. Mr. Chairman, back to you.
Okay, are there any questions from the public or from the board concerning this subject on 7A? If not, I'll entertain a motion to approve this subaward.
For the record, Larry Rackley, I make a motion to approve, for the approval of the notice of a subaward between the Epidemiology Office of State Epidemiology and Central Nevada Health District in the amount of $5,000 to fund activities for the prevention and control of M. tuberculosis pursuant to Nevada Administrative Code 441A and revised statute 441A, and conduct activities per the scope of work from 3/20/2024 through 12/31/2024.
Do we have a second?
Mr. Chairman, Bob Erickson for the record. I second the motion.
We have a motion and a second on item 7A. All in favor?
Aye.
Aye.
None opposed? Motion carries, and that subaward has been approved. We'll go to item 7B, consideration of possible action concerning approval of a notice of a subaward between Immunization Office of Child, Family, and Community Wellness and Central Nevada Health District in the amount of $19,591 to provide bridge funding to implement provider site visits specific to 317 storage and handling, and increase vaccine confidence and outreach activities to under and uninsured population within Central Nevada Health District from 3/21/24 through 12/30.
You've got a lot of health information available to you for planning, which is fantastic. And so we are taking those things into consideration. What we don't have statewide is an understanding of our infrastructure, our public health infrastructure statewide that helps us respond to all of those needs that we've identified. So the Foundational Public Health Services Assessment was designed, or I should say the Foundational Public Health Services framework was designed to represent a minimum package of public health services that every community should either have or have access to. It helps us set a foundation for what's needed everywhere for public health to function. As you know, communicable diseases don't recognize geopolitical boundaries, right? So we need to have a strong system everywhere to ensure healthy communities. It aligns with Public Health Accreditation Board standards and measures. That's important because in the event that Central Nevada Health District wants to work towards accreditation eventually, you'll already have a lot of the information you need, and you'll understand what assets and gaps you have as you work towards that process. And then it also helps, again, from that county perspective, identifying assets and challenges, as well as opportunities to collaborate regionally. Really just, same graphic here, but the thing I really want to highlight is that it's an assessment of public health infrastructure. So, it together with a community health needs assessment that identifies maybe those like risky behaviors or maybe, prevalence of certain kinds of diseases or risk factors, including kind of environmental concerns or what have you. This is, what do we have in place to respond? And so I'm going to see if this fun aspect of this clicker works to highlight. Okay, maybe not. That's okay. I know it's quite small, but something I want to highlight here across the top, there are 5 bubbles. Those are the foundational program areas. And so when we talk about foundational public health services, we're really talking about 2 groups of things. We're talking about the 5 foundational program areas, and then those 8 boxes across the bottom, those are the foundational capabilities. So what's the difference? So the foundational areas are communicable disease control, chronic disease and injury prevention, environmental public health, maternal, child, and family health, and then access to and linkage with clinical care. So nationally, public health professionals say, hey, these are the 5 program areas that every individual should have access to, and these form the foundation of public health. If you take a look at the foundational capabilities, these are, I really think of them as like the skill sets that support strong organizations, in addition to kind of having that public health lens. So it's assessment and surveillance is one, for example, emergency preparedness and response, policy development, right? Even, in local governments, you are responsible for policy, right? Or I'm sorry, as commissioners and boards, you are responsible for policy. So having people in place that can support you with good policy development, strategy, and information is important. Additionally, you'll see communications. So if the health department does an amazing job of identifying certain health issues, but does not have communications in place that, let the public know what's going on with those particular, public health issues, it's not going to be super effective. So what this assesses is not just those core program areas, but also what are those capabilities that help, really any kind of organization to be strong, but specifically a public health organization. This is an example of what the slide looks like. So in a moment, what the survey looks like. So in a moment, I'll talk a little bit more about step-by-step how we go through these assessments. But in short, it's a survey. It's an online survey. It's built into Qualtrics. That's an online survey tool. This is just a PDF snapshot. But as you can see, this is for communicable disease control. So what we're doing is we're asking professionals in the Central Nevada Health District who have knowledge of public health services across the jurisdiction, what is the level of expertise, the level of capacity, and the level of program implementation across each of those program areas and program and foundational capabilities. So here, for example, for communicable disease control, it's kind of bare bones right now, just so it's easier to look at, but we would ask only those who know about communicable disease control. What's the level of expertise, capacity, and program implementation? And then what I think will be very helpful for you all, probably most helpful for you all, is this free response section. So you'll have listed by state of Nevada, by county, by regional health district, and also by community supported services. So for example, not-for-profits, tribes, hospitals, all of the many partners that support you, their services for that particular program area will also be listed. So you'll have a really good understanding of who's available to respond to various needs and who's providing it. So this is not accurate. It's just for show right now because we're in the middle of this process, but this is just one data set that'll come out of this. So this is for level of implementation of both foundational areas and foundational capabilities. But as you can see, for Central Nevada Health District, you'll be able to see, okay, where are we fully implemented? Where are we, where are services absent or minimal? And where do we need to focus across all of our jurisdiction? So I like to put these up there to give you a sense of how this has been working nationally. So Washington State did this in 2018. I know it just looks like a checkerboard, but basically, the way this process has been handled in other states is that local health departments actually fill it out. It doesn't go to, an expanded body of experts in the community to fill out. But that doesn't work for Nevada because we don't have the local health department infrastructure across all of our state. As you may know, we're a hybrid state. Some places we have health districts, other places we have the state as the health authority. And so at NACO, what we said is like, okay, well, we're in the business of supporting county governments, and we also know that local decision-making really empowers the best and most sustainable development of programs. So we're going to do this same process, but we're going to modify it and do it at the local level. And so instead of going only to the leaders of health departments, although where they exist, and for Central Nevada Health District they do, we include, it's a partnership process, but we say, okay, who else in the community can weigh in on what the public health infrastructure looks like? But for Washington, when they did it, this is by local health jurisdiction. So their leaders at each of those local health jurisdictions weighed in and said, here's how we're doing in level of implementation across all of these foundational areas. And as you can see, Washington State's actually one of the states that has been working on this the longest. Ton of gaps, right? There's some things fully implemented and going really well, but there's still a ton of gaps. So the other thing I want to, share here is that foundational public health services is a great benchmark for us. It's also aspirational. It'll be a while before we're fully implemented across all of the foundational program areas. And so as we go into this process, it's really about, the transparency of what's there and being able to inform planning and, help us recognize that that it's going to be a long game of developing these services if Nevada's, anything like our national counterparts, which in some cases where we have less infrastructure, but more opportunity to build it well the first time, which is great. Okay, so Oregon, this is just another example of another state that took a look at this. I'm happy to provide the board with the full studies that, any of the states that have already done FPHS assessments have put out. They kind of continue to iterate, so there's a lot of literature out there to support it. So for you all, timeline and next steps. So we really want to encourage the Board of Health participation in their local jurisdiction. Of course, feel free to participate, across the jurisdiction, but we are going to host meetings in each county. For Churchill, please, Fallon, Churchill, please, participate in the process to the extent you can. And then also we're hosting meetings in Mineral, Eureka, also in Pershing, and really, I kind of got ahead of myself, so let me take a step back. The first part of it is this, speaking with you all today. The next step is that we'll do a Zoom kickoff with survey participants. They've already been, the lists have already been drafted, but we are absolutely welcome to input on who else to include. It's meant to be as inclusive as possible to get all of the right folks into that process to fill out the survey. We distribute the survey after the kickoff call. We're going to do that kickoff call tomorrow. The survey is open for 3 weeks. Nobody fills out the whole thing. It's dense, it's complicated. People only fill out the part that's relevant to their area of expertise. Agencies can receive a single survey, or they can distribute among their team and complete it. And then the last thing is these 3-hour community meetings. And I know that's a long amount of time, but actually we need the whole 3 hours. And what we do is we review and verify all the information that's been collected so that the data set we give back to you is complete and accurate. And so we have those scheduled on the following dates in Lovelock, Fallon, Hawthorne, and Eureka. And that's all. So happy to answer any questions, go back to any slides. And thank you again.
You had Mineral on there too. Can you back up to that? Yeah. You had Lovelock like the 13th.
Sorry about that. There we
You had
go.
Lovelock on the 13th, Fallon on the 20th, Hawthorne on the 22nd, and Eureka on the 23rd.
That's right. Yeah. So with this timeline.
Would you advertise the public to come to those, or?
I mean, we don't actually. I mean, it's not a closed meeting, but it's not intended to be. It's really not. It's not a community health needs assessment in the way that the public can easily fill that out and say, here's what our health needs are, here's what our health concerns are. It's so specific. So actually, if we go back to this slide, the survey will say something like this, like, what are the communicable disease control services available by providing entity?
So you want like agencies in
That's
the
right.
city.
Yep, agency
And the
heads
county.
and the leaders who have expertise across these areas. So I'll go back to this slide.
You want the people that are on the ground. You don't necessarily want their boards there.
That's right. Unless their boards have a really good understanding of like all the operations. But what's happened at a number of agencies, for example, hospitals, they usually get a few people involved. Health authority, like the health district, will have their whole team involved. So it's rare that any one person even at an agency can list all the services across all the areas. So what we do is we just say, hey, take a look at all of these areas and capabilities. Who on your team has expertise in any of these areas? And be generous about it, right? Because we're gonna verify it anyway. So if you're not sure if that person knows something about this, but you think they might, send it to them because they can put that in there. And really, we're trying to get as close to the source as possible, because one of the things I'm sure you've seen is that an agency or an organization will have a service and then it goes away. Maybe it's not staffed. Maybe it's they lost their grant funding. I mean, there's all these things why it might have gone away. And so we're trying to not utilize, whatever might be in a Google search, but instead ask leaders from agencies to say, what do you actually do? What are the limitations, right? Do you only serve a particular population? Do you not take certain insurance? Do you, are you only open this day? And it really is best filled out by the providers of that. And then in the community meeting, we can verify, right? So you've got all your peers around saying like, okay, well, you're saying that that's doing this, but actually someone told me they went in and no one was there. And then someone would be like, oh yeah, well, we had to close that day, because of X, Y, Z. So it just allows us to, the public can absolutely participate, but what we don't want is, anecdotal information shared, right? Like we want the experts who know what systems are in place to share what systems are in place.
So are you sure you can identify in each of those communities, those key players to send that to?
So that's a great question. What I would love to, so I've shared the draft list with the Central Nevada Health District leadership to, help us identify additional people. UNR Extension was really helpful in identifying as well. But no, I wouldn't want to overstate my ability to do that. So what I can do is share that.
I don't mean you, I didn't mean that.
Oh, no, but truly, it's really hard to identify those people. So what I've seen happen in other jurisdictions so far where we've done this is that, one, I'd love to share the list with you all and then you can add people and we can add them into the survey. It's open for 3 weeks. So it's a lot of time really to fill something like this out if you only do your area. So there's that. But another thing I've discovered as we've done this is that after someone goes in to do it and really gets a better understanding of what it is, then they're like, oh, I think someone else should be doing this. And so in every area we've done it so far, we've gotten emails throughout the process like, hey, could you send it to so-and-so? Like they really should fill out this section. And we get it as comprehensive as possible. Building up hospitals or building up clinics, we've spent less time investing in public health. So I think that's part of it. But to your question about like, have they improved and have they moved the needle on some of those from like a light blue to a dark blue? I don't know in what areas they have, but I do know that they continue to iterate on the process. So I can go back and find out, send you their latest update on this. But Washington does have really like a regular updating of their FPHS process. And they've taken the tack. They've actually gotten a lot of state general fund dollars through using the FPHS assessment to demonstrate the need. And they've taken the approach where they've said that's a state responsibility and the state needs to really support locals in order to do that. And so once they completed that and that went through the state legislative process, they've continued to get funding that then, comes back to support those foundational program areas.
I just wonder if those dark blues are in Portland and Eugene and Seattle and Tacoma, and you get out to the rurals and they're light blue.
I would not be surprised if that's the case because really it is
so in Nevada,
more difficult.
You would have 15 light blues and 2 dark blues.
Yeah. So it is.
And in mental health, it'd be worse.
Yeah. I bet that's correct. Yeah. So one of the things that's been interesting in learning more about these processes nationwide is that, rurality is absolutely a factor that gets taken into consideration because its services are more expensive to deliver. They're more difficult to deliver. There's workforce challenges that don't exist in the urban areas. So I think, really what you all have done in creating a health district is help mitigate some of that because in working together, you don't have to develop, county by county to get those services. But it's absolutely a challenge. And I do think that we have less, across the nation, there's less services in rural areas.
I didn't mean to interrupt you, I'm sorry, but there has to be a point to this to solve something.
Oh, for sure. Absolutely. Thank you. So, the point is to deliver a baseline data set to you all for decision-making purposes to use, however it is helpful to you and really however it's helpful to your local community. So we don't push a particular agenda with what you do with it, but what we do want you to have, and from a NACO perspective, what we want all counties to have is just the tools they need to make decisions. And, I think a lot of times what happens is we have, programs that come and go and it erodes community trust in the system. And we don't always know what's open, what's not open, what needs more investment, what doesn't need more investment. And so our goal at NACO is to give you the baseline of the infrastructure as it stands currently and to support all counties with that. And how you utilize it is up to you. But I would guess that how it will be helpful to you is that together with your community health needs assessment and the infrastructure assessment together with the health needs assessment will help you identify what is our community saying we need and what do we have in place that could support those needs. So if you have nothing in place to support a particular need, maybe that's not the first one you pick, right? Or maybe you're like, that's a long-term goal and let's focus on the things that we have some infrastructure for right now. Like those are the kind of discussions I think come out of a project like this. Yeah,
Okay, thank you.
no problem.
Does anyone else have any questions for Dr. Hines Sutherland? If not, we appreciate you coming today.
Thank you.
See you tomorrow.
Okay, great. Do you want me to-
Okay, we'll go to 9B, presentation from Dr. John Packham, Associate Dean for the Office of Statewide Initiatives, University of Nevada, Reno School of Medicine, regarding conducting a community health needs assessment for Central Nevada Health District.
Good afternoon. Again, for the record, I'm John Packham with the UNR School of Medicine. Been there almost 25 years, and part of the work I've been involved in has been working with the state's 13 critical access hospitals, one of which is here in Fallon, Banner Churchill Community Hospital. And the work that we've done with hospitals with respect to today's agenda item are community health needs assessments. And those assessments and our work with those hospitals, we've actually worked with all 13 hospitals. I completed 4 assessments in 2023. I have 3 teed up in Yerington, Pahrump, and Boulder City this year, and then I was approached to see if we could assist with one for this health district. I'm really excited about doing that because most of the assessments that I've done to this point have been trying to reach out and find out what the community is telling us about health needs, marry that with the existing data. There's plenty of existing data at the county level for all 4 counties that are a part of this health district, and then use that information. I've historically used that information to bring back to the hospital and the community about what can we do about what was revealed in this particular assessment. What I like about the opportunity to work with this board and the health district on this assessment is that we'd also like to use that information to inform what public health services or what roles are there for public health distinct from healthcare that we can use to inform the improvement and the protection of public health, and again in the 4 counties that are represented in this health district. I begin with the premise that most of what is driving health and health outcomes in Churchill, Eureka, Mineral, and Pershing counties occurs outside the walls of the hospitals in those communities, and the clinic in the case of Eureka County. With that said, then this gives us a really good chance, and I think kind of for the first time in the 4 counties that make up this health district, to kind of push the discussion beyond just what can healthcare do, what can clinicians do, and have this board and others think about how we address some of those upstream determinants. There was a great article in the New England Journal of Medicine earlier this week talking about how public health and healthcare are siloed, yet they're addressing the same problems. And I think we had that revealed during the pandemic, in which case hospitals like Banner Churchill became kind of the de facto public health agency. And I think now that the house is no longer on fire with the pandemic, we can take a step back and think a little more proactively what we can do, again, to address infectious disease threats, what's driving chronic disease and illness, what's driving injury rates, maternal mortality, and so forth. And so, again, over the course of this summer, We will be rolling out an assessment. It's going to have a couple of components. The first component is an actual data collection effort, unlike what Amy described, where she's reaching out to stakeholders who can inform her assessment of what public health resources and services exist. The survey I have in mind will be actually reaching out to the residents of those 4 counties and getting their take and assessment on what the key health needs and priorities are. Again, not just what can the healthcare system do, but what are the broader factors driving health. The second part of the assessment will be our attempt to analyze and utilize data that already exists. One of the data sets that I'm most familiar with is the County Health Rankings and Roadmaps that releases county-level data, including the 4 counties that comprise the district, on length of life, quality of life, health behaviors, access to clinical care, social and economic factors, physical, environmental factors, and so forth, so that it sounds like it's a huge data collection exercise, but I'm really going to be utilizing data that already exists out there. The great thing about the county rankings data is that it's not only a snapshot of what health and healthcare looks like at the county level for the purposes of this assessment, there's also trend data. So while if you look at, for example, obesity prevalence in the state of Nevada, Nevada and a number of counties, including Washoe County, look like they're doing pretty well, but those obesity rates have been on the increase over the past decade. Conversely, if you look at adult smoking and tobacco use, while our rankings don't necessarily look great in Nevada, those rates have been coming down. So it's important to take that current snapshot and assessment of what health and healthcare look like, but also to look at the trend data, and again, how the 4 counties that make up this health district compare with national and state benchmarks in the state. The final data source that I'm going to mine, because it's a relatively recent one, a fascinating database that my office has purchased access to, and that is what does inpatient and outpatient healthcare utilization look like from the residents of these 4 communities. And it's fascinating because, one, I think it's information the hospital will be interested in. That is, what are people driving to Reno and Carson City and parts unknown for healthcare that you could get right here in Fallon? And that was the genesis of our interest in that, is how can we assist hospitals capture as much of that market share for healthcare that is showing up in the inpatient-outpatient statistics. I also like to use it for these community assessments because that information is coded by diagnostic groups that tells you a lot about what's putting individuals or requiring individuals to seek hospital care in particular to begin with. And so it will shed light on health needs in this community. After listening to Amy's presentation, I think it would be really important for these 2 data collection efforts, we can discuss it later, to not overlap. We don't want the community confused about a sudden flurry of data collection, but I think it will, the analysis that I'll be working on will really complement what Amy's collecting, because at the end of the day, kind of the charge of the health district, as I understand it, is a good understanding of what are the public health and population health needs of this district, what resources can we bring to bear to address and stay on top of those issues, and then what additional steps are needed. And I'm again excited because I think I'll be informing a much broader discussion about some of those upstream population public health determinants. What I've done in the past, and I'll continue to do with this survey, is also see what the findings mean for the delivery of healthcare in your respective communities. Again, I've worked with the 3 hospitals in this district for close to 20 years since we initially got these facilities designated as critical access hospitals. And again, just excited to be a part of this project. The timing's good. I've done my taxes. I've gotten a couple of other projects off my plate. So of the spring and the summer, I will be eager to turn my team loose on this assessment and help this board and this district with the work that's in front of you. And you have plenty of work, as you know. Happy to take any questions.
You mentioned something, and I missed the word, but it was like access to clinicians or
Yeah.
access to clinics, or is this going to entail access to physicians?
Yeah, I typically include that kind of information in the survey. And one of the things I'm interested in is, what barriers do you face? And I don't limit that to finances and, whether you have an insurance card in your pocket. How long does it take to get an appointment? What is follow-up care like? If you're told that you need a specialist, and there's not a specialist in Fallon or Lovelock or Hawthorne, which is really severe in Hawthorne and Lovelock, what are you doing about that? And so, again, I have some existing data on that database that I referred to, but it's also nice to hear what individuals are telling you as well. And so, again, try to marry the two.
They would also, they would also tell you leakage of a certain area,
Yeah,
ENT, or, whatever.
absolutely. And there's plenty of that. It's painful. And one of the things that I am earnest about in doing these assessments is, give you a good example. We worked with the hospital in Winnemucca, Humboldt General Hospital. We did a feasibility assessment on setting up orthopedic surgeon to work, provide procedures for knees and hips. I almost messed that one up. Knees and hips in that community, recognizing that they have enough population, they have an aging population in that community, and to no great surprise, they have the demographics and wherewithal to support that new line of services that they implemented 8 or 9 years ago. Nonetheless, half the community still leaves Winnemucca for a service they could get right there at that hospital, for follow-ups to those procedures that they could get right there in the hospital, rehab facilities, skilled nursing that they could get right there in their community, but they still leave. And so I've got some great data in the case of Winnemucca on how much leakage there is there, and it's an opportunity for the facility to think more about what they can do on outreach and getting the message out, as well as demonstrating the outcomes. The outcomes are actually better if you get a hip or knee procedure in a community and aren't shuttling 200 miles back and forth, taking time off work, taking family members' time off work. There's so many economic reasons why the hospital needs to be on that, but I also would argue it's better care.
Okay, thank you. I appreciate that. I think that's really important to me to know. Doctors are, the board knows that's something that.
Well, Fallon's had some retirements,
and
and you have workforce shortages that have been enduring as long as I've been doing this for 25 years. We've also made progress in some areas, and to the extent this kind of analysis can inform strategies to address workforce shortages and access, I'm always on board.
Okay, thank you.
Yeah.
Any other questions from the board or the public?
Thank you.
Being none, I'd like to thank you for coming today, Doctor. Appreciate it.
Yep.
We'll go to item 10, which is public comment, general in nature and not relative to anything on the agenda today. Discussion can be held, no decision can be made. Is there any public comment? Being none, we'll go to item 11, which is adjournment. So with nothing else, we stand adjourned. Thank you all very much for
This
coming
conference
today
is no
and drive
longer being
carefully.
recorded.